Today we're going to cover the pharmacology of protein binding and its clinical significance. Let's start by defining what protein binding is. Protein binding describes the reversible interaction of drugs with proteins in the body. Now, drugs and proteins interact in such a way that they form rapid and reversible bonds which can be represented as a chemical equilibrium below. Before going ahead, pause the video here and ask yourself, what are 4 groups of proteins that drugs can bind to? Coming back to the video, drugs can bind to 1. Plasma proteins, 2. Tissue proteins, 3. Enzymes, and 4. Receptors. In terms of the major plasma proteins, they are albumin and alpha-1 glycoprotein. Key examples of drugs that bind to tissue proteins are digoxin and bupivacaine. Similarly, key drugs that bind to enzymes are acetazolamide and neostigmine. And many drugs bind to receptors to exert an effect. Now we're going to look at the key plasma proteins in more detail. Starting with albumin, it binds acidic and neutral drugs, and it has a high protein binding capacity due to high concentration in plasma. That is, there's a lot of it in plasma, specifically 40 grams per litre, and there's also multiple binding sites on albumin, for example, the warfarin and diazepam binding sites. It is a negative acute phase reactant, which means its levels fall during inflammation and illness. On the other hand, alpha-1 acid glycoprotein has many properties that are opposite to albumin. It binds alkaline and neutral drugs. It has lower binding capacity due to lower concentration and having only a single binding site. It is an acute phase reactant, which means its levels rise during inflammation and illness. Finally, lipoproteins are the last group. These proteins bind lipid-soluble drugs and steroid hormones. Next, we're going to ask ourselves, what are the factors that determine protein binding? I'll let you pause the video here so you can think for yourself first what these factors are before going ahead. Okay, back to the video. I've broken it down into 4 main determinants, which include protein binding sites, protein affinity, drug concentration, and drug competition. Starting with protein binding sites, this is affected by the protein concentration and the number of binding sites. For example, albumin has a higher protein binding than alpha-1 glycoprotein due to high albumin concentration in the blood, but also multiple binding sites. Consequently, there will be less protein binding when there is a fall in albumin, such as in cirrhosis. Second, protein affinity, which describes how well the drug and protein bind. This is affected by the association constant, such as that a high association means there is more binding. Lipophilicity, which means that the more lipid-soluble a drug is, the greater the protein binding. And tying into lipophilicity is the concept of ionization of the drug, which is determined by the pH of plasma and the pKa of the drug. Generally, the more unionized or uncharged the drug is, the more lipid soluble it is, and so the higher the protein binding. For example, an acidic drug in an acidic solution will be more unionized and consequently more lipid soluble, and thus it will have a higher protein binding. As a side note, ionization and pKa can be a confusing topic, so we'll spend some time on it as well as apply a helpful mnemonic to hopefully clarify ionization. The first mnemonic is AIA, which stands for acids ionize above pKa. So if a drug has a pKa equal to 3 and is in a highly acidic solution such as pH of 1, this would mean that a greater proportion of that drug is unionized, and this will increase lipophilicity and protein binding. The other mnemonic is BIB, which stands for bases ionize below pKa. So if we choose a drug with a pKa equal to 8 and place it in a highly basic solution, such as a pH of 11, there will be more unionized drug in this high pH, which will increase the lipophilicity and protein binding. Okay, going back to the factors that determine protein binding. We have already talked about protein binding sites and protein affinity. Now we'll talk about drug concentration. Generally, the higher the drug concentration means there will be increased binding until the protein is fully saturated. The final factor is drug competition. Two drugs can compete for the same binding site. For example, drug X will displace drug Y from albumin, which will cause a rise in the plasma concentration of drug Y, resulting in a risk of toxicity. This is clinically important when both drugs have a high protein binding, such as amiodarone and warfarin. This means that amiodarone can displace warfarin from albumin and cause a rise in serum warfarin concentration and a rise in bleeding risk. Okay, we're now going to pause the video and ask ourselves, what is the clinical significance of protein binding? How does protein binding affect what the body does to the drug? And how does protein binding affect what the drug does to the body? Basically, the unbound fraction of drug in plasma, that is the portion of drug not bound to proteins, the free drug, is the pharmacologically interesting part of the drug. What do I mean by that? The unbound fraction is the only part that can cross cell membranes and exert an effect. It's also the only part that gets metabolized or eliminated. We're going to look at the clinical significance of protein binding in more detail, and to help us to remember the clinical significance, we're going to divide it up into pharmacokinetics, namely distribution, metabolism, and elimination. Then we'll look at the pharmacodynamics and protein binding. Starting with pharmacokinetics, in terms of distribution, drugs with high plasma protein binding tend to have lower volume distribution since the drug is mostly confined within the plasma. For example, aspirin, warfarin, and enoxaparin. Drugs with high tissue protein binding tend to have a much higher volume distribution since the drug spreads widely throughout the body. For example, digoxin has higher affinity for cardiac proteins than plasma proteins, which causes digoxin to have a high volume distribution. On a related note, protein binding can act as a reservoir, and this prolongs half-life and elimination. Next, onto metabolism. As we said before, only the unbound fraction or the freely floating drug in plasma can be metabolized. Therefore, increased protein binding will mean that there is less drug available to be metabolized, and this will prolong drug half-life. Thirdly, elimination, where only the unbound fraction of drug can be eliminated. Therefore, drugs with low protein binding, such as penicillins, can be easily filtered and eliminated at the glomerulus in the kidney. This means they will have a short half-life and require increased dosing frequency to maintain a therapeutic drug concentration. Moving on to the next major heading, pharmacodynamics. Generally, the unbound drug fraction can diffuse and act at the effect site. Therefore, when there is increased free drug, there will be more drug at the effect site, which will cause a stronger response. In terms of duration, drug action is prolonged when there is increased tissue protein binding. For example, bupivacaine has prolonged binding to voltage-gated sodium channels, which means that there is a prolonged duration of action, since bupivacaine does not frequently dissociate from the effect site. Next, we'll recap drug competition, which we've already talked about. Essentially, highly protein-bound drugs can compete for the same binding site, and this can cause adverse effects. And the example we used was amiodarone and warfarin. For disease states, we've already talked about how low albumin, such as during critical illness, can cause increased unbound drug. But we'll go further to explain that this can cause 1. An increased drug effect because there is now more free drug, but also 2. Increased metabolism and elimination of the drug, which will shorten drug duration of action. Lastly, we'll look at drug monitoring and protein binding. When drug levels in the blood are being monitored, they measure the total drug amount in plasma, which is made up of both the bound and unbound fractions. This has important implications in hypoalbuminemia, where the total drug level is low because there is less albumin for the drug to bind, therefore there is less bound fraction. However, the unbound fraction of the drug may remain constant. And as we've mentioned many times before, it's the free drug that is pharmacologically interesting. That is, it's the part that exerts an effect or is metabolized. Consequently, if we increase dosing based on a total drug amount which is low because of low albumin levels, we can cause toxicity as it will increase the unbound drug fraction since the albumin is already saturated. Therefore, it is important to correct for albumin and check free drug levels when monitoring drugs with high plasma protein binding, for example, phenytoin. Okay, let's recap what we've just learned. We define protein binding in terms of a rapid and reversible reaction, which can be summarized by the chemical equilibrium equation. We talked about the 4 protein groups that drugs may bind to, including plasma and tissue proteins, enzymes, and receptors. We focused on the properties of the 3 major plasma proteins, albumin, alpha-1 glycoprotein, and lipoproteins. Importantly, albumin binds acidic drugs with high capacity and multiple binding sites. We looked at the 4 factors that determine protein binding sites, including protein concentration and the number of binding sites, protein affinity, including association constant, lipophilicity, and ionization, drug concentration, and drug competition. We talked about the clinical significance of protein binding and that only the free, unbound drug is pharmacologically interesting. We then broke the clinical significance into pharmacokinetics and pharmacodynamics. In terms of pharmacokinetics, protein binding can affect drug distribution depending on whether the drug binds to plasma or tissue proteins. The body is only able to metabolize and eliminate the free, unbound fraction of a drug. In terms of pharmacodynamics, the unbound drug can exert an effect. High tissue binding tends to prolong the duration of action. Highly protein-bound drugs can compete for the same binding site and cause toxicity. Disease states that cause low albumin will increase the unbound fraction, meaning there's a greater drug effect, but also more drug being metabolized. Finally, we looked at drug monitoring and we highlighted the importance of considering albumin concentration and titrating drug dosage based on free drug levels. Alright, that's the end of the video. Thanks for watching, guys. Make sure to subscribe if you're new to the channel and please like the video if it's helped you out. Please comment below for any questions you have or topics you want me to cover in the future. And just remember, every day you are learning more and more.